All right. Today we're going to look at a condition known as glomerulonephritis. So glomerulonephritis, this is one of the renal disorders common in babies or pediatric cases. So right here, you can see already this child with some signs of GN, or what we refer to as glomerulonephritis. So first things first, what you see is that this condition affects the kidneys. What I want you to quickly remember is the functions of the kidney. So functions of the kidney are quite many. Most importantly, this is the organ of excretion. It's the main organ of excretion, meaning most of the things that we eat, especially converted in fluid state, beverages, drinks, tea, and so on and so forth, regardless of what substance, it has to be excreted out of the body. The physical matter that we ingest, most of the thing is excreted by the digestive tract. Now, the waste that goes in blood is excreted by the kidneys. Now, in an event that there are problems in the kidneys, one of the earliest signs you're going to see is problem with fluid balance. The amount of fluid that the body will have. Either the body will lose more of fluid, body becomes dehydrated, or that filtration is lost, where much of the fluid is conserved within the body, hence resulting in such a case like this baby we're seeing here, where they've developed edema. Right here, I have a question extracted from one of the questions I created concerning glomerulonephritis. Of course, we're looking at the baby who's 3 years old, the periorbital edema, and after some, investigations, the baby is diagnosed with acute glomerulonephritis and admitted to the PEDS wards. One of the questions I wanted my students to answer is I want to know if they have a solid understanding of the urinary system, so I asked them to draw the nephron in details and label it. I gave that part 20%. The other part is I want to know if the students understand the basic concept about this condition. So I can assess that knowledge by understanding if the students are able to write or explain the pathophysiology of glomerulonephritis. And finally, I want to see if they're able to detect this condition. Should a patient present, should be presented to them. So I was asking about the signs and symptoms. Then finally, I want to see if they know the basics of managing such kind of a patient. Of course, basics are very important. So medical-wise, what is their knowledge? The nursing-wise, what is their knowledge? So when we're done with this discussion, I'm sure I should be able to come back to this slide and see if you're able to attempt these questions. And when you begin to attempt these questions, I want you to close your books, to close any source of information and just answer from the way you have understood. It's important that you can time yourself. So under normal circumstances, you are supposed to finish this single question under 45 minutes. So between 30 and 45 minutes, you should be able to finish from A up to D. Then you are safe to complete an exam. So before we even go further discussing this condition, I want us to look at the urinary system. Most importantly, one of the main organs of the urinary system is kidney. Now, kidney, also known as a renal organ, when cross-section, when it's cut, what are the parts you're going to see? So most importantly, you're going to see that the kidney is made up of a darker region or brownish central region called the medulla. So that's the medulla. Now, this region is divided into pyramid-shaped structures. So you see that this is more like a base. This is the apex of the pyramid. So some books will say pyramidal or pyramids, referring to the medulla. So roughly there are about 8 or so pyramids, 8 to 12 pyramids in each kidney or cortex, medulla. Then the surrounding area is the cortex, more reddish in color. That is the medulla, and that's the cortex. Then the cortex separates the medulla with its columns. So that's the cortex column, 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 column. That space there. So that's a column, or what you can say the cortical columns. So those are the columns we are looking at. Then we have a medulla papilla, that area where each medulla is connected to the minor calyx. That's a minor calyx there. Then this will be a major calyx. So major calyx divides into minor calyx. So there are about 3 to 4 major calyx, and then each major calyx divides into 3 to 4 minor calyces. So that's one major calyx. That would be a minor calyx, the end. Each minor calyx connected to the renal papilla, where urine formed enters now the collecting part of the kidney. This becomes the renal pelvis, eventually leaves the kidney as the ureter. Now, the gross part of the kidney is not so useful when discussing glomerulonephritis. I want us to look at the histological part of the kidney, the microscopic part. We are looking at a nephron. So this is a nephron. We're saying each kidney has about 200 to 300 million nephron in a full-grown kidney. That's about 2 years going up, right? But the number of nephrons keeps on fluctuating, goes down, especially with age, the number drops. So what are the major parts of the nephron? Remember on one of the questions there, I was asking my students to draw the nephron. So the following parts should be there. You must draw the Bowman's capsule with its glomerulus, together known as the renal corpuscle. So this is the renal corpuscle. Renal corpuscle has 2 parts, glomerulus and the Bowman's capsule, or the glomerular capsule. And that's the renal corpuscle. Then the first part will be the proximal convoluted tube. You look at that. Oh, excuse me. That's a proximal convoluted tubule. Then from the proximal convoluted tubule, we have the loop of Henle. That's a loop of Henle. And then we have the distal convoluted tubule and the connecting tubule. Then that is a collecting duct. Then in your drawing, you must be able to show that we have vasa recta associated with the loop of Henle. Then you have the peritubular capillaries associated with the proximal and distal convoluted tubule. So these are capillaries around the proximal and the distal. They are known as peritubular capillaries. Then we have the vasa recta. They are also capillaries, but associated with the loop of Henle. So in your labels, at least you should have those major parts labeled: glomerulus, Bowman's capsule, proximal, distal convoluted tubule, loop of Henle, collecting tubule, and the collecting duct. Then you add the afferent and efferent arterial. In this case, this is the afferent. Just a moment. Okay. Just a minute. All right, so I can't see what is up there, but usually the afferent is smaller than the efferent. I don't know which direction here. Yeah, this is the efferent. This is the afferent. Afferent arterial. This is efferent. Afferent bringing blood here. Efferent taking blood away. So this is a drawing you should know. When it comes to conditions of the renal system, you must be able to know how to draw and label a nephron. Some questions I may ask you to draw and label a cross-section of the kidney, and these structures should be there well labeled. So let's quickly dive into our program today. So this is just a magnification of the renal corpuscle to show us that there's a glomerulus, and the Bowman's capsule has 2 layers of squamous cells. Squamous cell, squamous cell. Now, even the blood vessels are also made up of squamous cell, simple squamous cell. So together, this squamous layer and the squamous layer of the capillaries, plus that white part there, the black layer there, forms what we call the basement membrane. So basement membrane is made up of the basement membrane of the squamous of the glomerulus and the basement membrane of the blood vessel. So three structures form what you call the filtration barrier or membrane. Squamous cell of Bowman's capsule, squamous cell of blood vessel, plus the basement membrane in between. So whatever is diffusing from blood into the renal space here has to negotiate through those three layers: squamous cell of blood vessel, basement membrane, and the squamous cell of the Bowman's capsule to reach that space. Then becomes the glomerular filtrate. So when it comes to glomerulonephritis, the term, it says glomerulonephritis, meaning there's injury to the glomerulus. Which part of the glomerulus? Specifically the basement membrane. Here, I have another diagram that will show us that in a greater detail. So these are simple functions of the kidney. You can look at them in your own free time. So what is the function of, what is the definition of glomerulonephritis? It's a disorder of the urinary system in which there's damage of the glomerular basement membrane resulting in reduced glomerular filtration rate, proteinuria, hematuria, periorbital edema. These are one of the major signs and symptoms that the baby will show with filtration will drop, meaning urine output will reduce, so patient will have oliguria. Then there's proteinuria because of the damage to the basement membrane. Proteins will be found in urine, some portions of blood, and the blood fluid shifts from blood vessels into tissues because you have lost plasma proteins, which maintain the oncotic pressure of blood. So here is a diagram showing us a more detailed structure of the basement membrane. So this is the afferent arteriole. Of course, it is always slightly larger than the efferent arterioles to create pressure here. Then you have what you call mesangium here. This is connective tissue of the Bowman's capsule made up of mesangial cells. So these cells are connective tissue and they play a very important role in the Bowman's capsule. They act as connective tissue. They act as protective cells. So they are phagocytic in nature, mesangial cells. So those are mesangial cells. Now I want us to focus on one thing. Number one, this is a blood vessel that has been cut. So we are seeing it from a superior view. That's the entrance here. Now you see that each blood vessel will be surrounded by particular cells called the podocytes. So these are podocytes. So podocytes surround blood vessels. That's a podocyte. Now, around between the blood vessel and the podocytes, you find the basement membrane here. See that? That's a basement membrane, bluish in color. Basement membrane. Then these are podocytes. So whatever happens to the filtrate, for it to leave the blood vessel and reach the renal space, it has to diffuse through the capillary, which is the glomerulus, through the basement membrane, and these tiny spaces, the slit diaphragms found between the pedicles of the podocyte. That's a pedicle of the podocyte. Podocytes have more like finger-like projections. These are pedicles. Then you have the slit diaphragm, those spaces left by the pedicles. Then there you have the simple squamous layer of the glomerulus, which is not shown here. So that those are the layers the filtrate pass through. Simple squamous layer of blood vessel, basement membrane, and the simple squamous layer of the Bowman's capsule. Then collect here as the filtrate. Now, in this particular condition, we're saying there's damage to the basement membrane, this layer. Because when blood is brought to the glomerulus, diffusion occurs. Smaller molecules diffuse into the mesangium through the basement membrane and collect here. And that's what we call a filtrate. Now, in these babies with the glomerulonephritis or even adults, they are what we call immune complexes in blood. So this results from reaction of the body to certain microorganisms, certain antigens. One of them is group B, group A, beta hemolytic streptococcus. So such antigen antibody reaction from such kind of microorganisms are very difficult to eliminate from the body. So when they diffuse from the blood vessel, they're the ones that come and cause damage to the glomerular basement membrane. So they'll create pores here, spaces, that is now easy for what is here to cross from the blood vessel through the damage into the renal space. So even large molecules like cells, plasma, proteins will find themselves as part of filtrate, which doesn't occur in normal cases. So the main issue when it comes to glomerulonephritis is damage to this layer, basement membrane, by immune complexes. Sometimes it could be toxins. Someone was bitten by a snake, or maybe they ingested some toxic substances and so on, and that causes damage to the basement membrane here. Before I leave this part, I want to turn your attention to this type of cells found here. These are called the juxtaglomerular cells. These are JG cells. These cells are important for production of renin. So renin is an enzyme that activates angiotensin to angiotensinogen to angiotensin 1. Then angiotensin 1 is the one that is converted to 2 when blood circulates through the lungs. So those are the juxtaglomerular cells. Juxta meaning closer. That's a glomerulus, and these cells are closer. So hence the name. So what are we going to see in this type of condition if there's damage to the glomerulus? So we find blood cells, plasma, proteins in urine, which is not a normal finding. This is not correct. So this is a healthy urine. There is no plasma protein. There are no blood cells. So look at the consistency. It's amber. This one is a bit pinkish reddish because of presence of blood, and then it's forming. It forms there because of presence of plasma proteins in the urine. So already that can point to glomerulonephritis. So acute glomerulonephritis affects the children in that age range, and in most cases, about 30% progresses to nephrotic syndrome or renal failure. That can actually cause serious problems for these babies. Only a few babies, about 1%, may develop end-stage renal failure as a result of glomerulonephritis. So affects more males than females. That's about 2-to-1 ratio. Yeah. I don't know why it is like that. Maybe we can discover that much later on in our discussion. Yeah. Let's look at the etiology, the causes. Number one, it could be bacterial infection. So bacterial infection mainly is group A beta hemolytic streptococcus, which causes upper respiratory tract infection, later on which becomes a blood infection, starting with the heart, causing infective endocarditis, and can actually cause valvular incompetence. So 90% of babies with the glomerulonephritis are as a result of this infection. They will have tonsils, they will have some type of respiratory tract infection, which complicates into carditis and eventually nephrotic syndrome. So usually you want a history. When you're handling such babies, you want to know if they had any upper respiratory tract infection prior to this. And we're saying 90% of babies, there will be a positive history of upper respiratory tract infection. Other infections can come through, for example, pneumocystis carini, or formerly known as Girovecchi, which causes a certain type of pneumonia. Salmonella typhi, this causes typhoid fever. Then secondary syphilis by Treponema pallidum. So syphilis has two causes, three actually. There's what you call primary, secondary, and tertiary syphilis. Yeah. So in the early stages, you see a chancre, a sore on the site where the Treponema pallidum entered the body. It could be the genitals, oral cavity, and so on. Then signs will come up, then later on subside. Then may come through again as secondary syphilis, or later on as tertiary syphilis affecting the heart, nervous system, and other system like the skin or integumentary system. Then other sexually transmitted infection, Neisseria meningitidis, causing meningococcal meningitis. Viral infection, there are quite so many. Hepatitis B is common, mumps virus, measles, and so on. Parasitic, mainly is malaria and toxoplasmosis. Now, apart from infection, There are other disorders that can also lead to damage to the basement membrane of the glomerulus. Example given are autoimmune disorders. Common among these is the SLE or systemic lupus erythematosus, which is an autoimmune disorder affecting various systems, among them the renal system, reproductive, digestive, including nervous system. So the body is producing antibodies against itself, causing damage to that. There's what is called Goose-Passer syndrome or simply anti-glomerular basement membrane disease. So here the body is producing antibodies specifically that destroy the basement membrane in the renal system and portions of the lung. So this patient will be complaining of signs and symptoms to do with urinary system and respiratory system. Then other disorders where there are antibodies produced against the kidney itself. So what triggers such kind of autoimmune disorders is not clearly understood, but usually follows a certain type of infection. It could be a viral infection or simply heredity. Individuals born like that, where at some point the immune system overreacts and attacks itself. But usually there's either a viral infection prior that switches off the ability of the body to identify self from non-self and causes such problems. So that's number 2 category of causes. Yeah. Then you have vascular disorders, for example, hypertension, vasculitis, and disseminated intravascular coagulation or coagulopathy. So in terms of hypotension, here we're looking at insufficient perfusion of the kidney, where blood flow to the kidney is reduced. Maybe the patient has some heart problem or simply cardiovascular disorders. For example, they have some coarctations of valves or coarctation of vessels in certain parts of the body leading to the kidneys. Vasculitis, this can be caused by various infections or toxins in blood. Talk of bee stings, snake bites, and so forth. Disseminated intravascular coagulation, of course, this can be switched on by so many factors, and actually causes micro occlusion of blood vessels that supply to the kidney, causing death to the glomerulus basement membrane. Yeah. Then metabolic disorders, mainly diabetes mellitus, blood becomes so thick and viscous, causing injury to the either afferent or efferent, or indeed the basement membrane inside the glomerulus. Then other causes could be irradiation during management of tumors, then wrongly administered vaccines, for example, diphtheria pertussis and tetanus, that induces formation of antigen antibody immune complexes. So that's why we need experts to deliver such kind of vaccines in the right route and the right site. And then serum sickness, these are various infections that affect blood. So there are quite so many causes you need to just pick. Classification, how do you classify glomerulonephritis? So the first classification, we base it on disease origin. Where is the disease starting from? Is it the cause of the disease? Is it starting direct from the kidney itself? Or there's a problem outside the renal system, which later on affect the kidney? So if the cause is resulting from within the renal system or from within the kidneys, then it's called primary glomerulonephritis. So this is caused by nephrotoxic drugs or agents and biological toxins, for example, bee stings, snake bites, and immune complexes. Common among them is this immune complex from group A, beta hemolytic streptococcus. This is a leading cause. So the cause is directly there in the kidney. There's damage to the basement membrane. Secondary glomerulonephritis, the cause is extra-renal. We have an underlying disorder somewhere which complicates into glomerulonephritis. Example is syphilis, infective endocarditis, and autoimmune disorder. The problem is immune overaction here. The immune system is unable to identify self from non-self and causes auto damage to organs such as the kidney, lungs, and other parts of the body. Even the heart sometimes is attacked. Then there's also classification of glomerulonephritis based on microscopic changes. So this one, you need a sample, a biopsy, to see what kind of changes have occurred in this kidney of this patient who's having glomerulonephritis. So we have what we call diffuse glomerulonephritis or diffuse GN, characterized by proliferative increase in cell number. So in majority of the glomerulus in the kidney, we said we're about 200 to 300 million nephron. Now, if you examine the cells, they are mainly the mesangial cells. You find that there's hyperplasia. Let me just go back here. The number of cells are increasing in that space. So that is called the diffuse glomerulonephritis, and it's affecting majority of the glomerulus. It's not just one glomerulus affected, multiple glomerulus in the cortex there are affected. Then we have what's a membranous glomerulonephritis characterized by protein-based deposits on the basement membrane. So some of the immune complexes will be deposited on the basement membrane here. So you find protein-based deposits on the basement membrane, and those are the ones that are causing damage to the basement membrane here. So different from diffuse, where there's hyperplasia of cells around the glomerulus. Then membranous, there's deposition of protein-rich deposits on the basement membrane. Okay, then finally, we have classification of GN based on duration and onset. So there's acute, which is sudden inflammatory changes in the renal glomerulus and causes oliguria and rapid accumulation of interstitial fluid in the body because of loss of proteins. So edema rapidly manifests. Then we have chronic glomerulonephritis, of course, follows untreated or unresolved acute glomerulonephritis, or repeated episodes of acute glomerulonephritis is considered as chronic glomerulonephritis. So those are the classifications. We're looking at it based on the origin of the problem. Origin of the problem within is primary. Outside, secondary. The macroscopic changes we have diffuse, where multiple glomerulus are affected and there's increased proliferation of mesangium. Then we have presence of protein-based rich deposits around the basement membrane causing damage to the basement membrane, known as membranous. Then finally, acute and chronic glomerulonephritis. Those are the three classifications. Should the question ask you, define or state types of glomerulonephritis, you have to list all of them from the three classes we've talked about. List 1 and 2 from based on origin. You go 3 and 4 from microscopic appearance, and 5 and 6 from duration. Or you can start from the bottom, acute and chronic, then you add the others. Okay, so here is a pictorial representation of what we're trying to talk about. Primary starts from the glomerulus, secondary outside the glomerulus, acute, sudden onset of signs and symptoms and requires prompt treatment. Then we have chronic, which is repeated glomerulonephritis or develops insidiously or slowly over a longer period of time. Then we have diffuse and membranous glomerulonephritis. So, in this discussion, we'll focus on the duration, because this is the commonest classification. So, acute, characterized by sudden inflammatory changes in the glomerulus and Patient presents with hematuria, presence of blood in urine, which is an abnormal finding. Hypertension, loss of renal function, mainly glomerular filtration rate drops. So patient develops oliguria. Then there's almost always a history of upper respiratory tract infection such as tonsillitis, pharyngitis, or skin infection, impetigo. All these are associated with group A beta hemolytic streptococcus. This is a notorious microorganism associated with glomerulonephritis. So what about chronic? Yeah, so chronic is quite not so different from acute. I'll come back to that. So chronic glomerulonephritis is categorized as either a slow progressing glomerulonephritis or repeated episodes of glomerulonephritis. Now, in this case, you may find that there is no history of any upper respiratory tract infections, and renal function keeps on deteriorating over a period of time and actually may result into renal failure because of the progressive damage that occurs to the kidney and its function. So let's look at the pathophysiology of glomerulonephritis. I'll be brief, just focusing on some of the main points that you must be able to explain. Number one, we're going to start with the commonest cause of glomerulonephritis, which is infection with group A beta hemolytic streptococcal infection. Now, this infection may subside later, all right, and is treated with antibiotic therapy. Now, the body also tries to fight this infection. Now, in the process, they form what are called insoluble immune complexes. So these complexes are very difficult to dissolve and get rid of by the body, mainly the urinary system. So they remain solid. And as they try to pass from the blood vessels to be part of the glomerular filtrate, that's when they cause damage to the basement membrane. Mhm. So why are they insoluble? It's because the type of infection that we're talking about, group A beta hemolytic streptococcus. So when blood containing such complexes passes through the kidneys, these complexes become trapped or deposited on the basement membrane. Remember, I showed you the basement membrane. Must be somewhere here. Oh my goodness. We're going too far. Yeah. So the immune complexes are here, the insoluble one. They're trying to, because filtrate passes through those tiny, tiny spaces. Remember, in the kidney, we have what you call fenestrated capillaries. These are fenestrated. They have those tiny, tiny pores. So as it's trying to filter blood, the complexes also pass through the fenestra, but they can't pass through the basement membrane because it's solid. They become trapped there with constant exposure because they are foreign. The body should get rid of them. That's when the damage occurs, eventually creating large, large pores that allows the plasma and this composition to leak and become part of urine. So we find blood cells, white and red, together with plasma protein. So that's where we are. Immune complexes in blood passing through the kidneys, and then they become trapped in the basement membrane, causing damage to the basement membrane. Okay. Now, what follows after damage to the basement membrane here? When it is destroyed, what follows is decreased glomerular filtration rate, loss of electrolytes, and loss of plasma proteins. So, if glomerular filtration rate drops, urine output also will drop, so there will be oliguria. Electrolytes and plasma being lost, that's why the urine is foamy. It gets a foam when collected or when the baby is urinating in the pan. Yeah. Now, because blood is losing electrolytes, you see that this will affect the fluid volume balance, electrolyte imbalance in the body. That's why the baby may be weak, and they may experience, episodes of some mental disturbances. They may have cramps in the muscles, the large muscle groups. Now, because they're losing protein, and protein help fluid to remain in blood vessels. Should the blood vessels lose this protein because there's damage in the basement membrane, then fluid also shifts from the blood vessels into tissues, causing edema. Yeah. So, of course, there's fibrosis, which is scarring and atrophying of renal tubules. But with time, because the kidneys are failing to filter, filtration rate drops. Creatinine and urea and other nitrogenous waste begin to accumulate. So at some point, this baby may develop azotemia, a condition in which there's excessive accumulation of nitrogenous waste. So what do we see in this baby as a result of this disorder? Number one is that there will be proteinuria, presence of protein in urine due to damage to the glomerular basement membrane. Hematuria, presence of blood in urine due to damage to the capillaries and the basement membrane. Then specific gravity of urine increases due to reduced urine output. So blood becomes urine, sorry. The amount of urine drops and the color changes. Urine will appear more brownish or orange. Just know that the specific gravity has gone high. The number of solute in urine is going up because fluid is being retained in tissues. So that's how you should end your pathophysiology. You explain what is happening and at least give 1, 2, or 3 signs and symptoms. Yeah. So this is leading us now to the signs and symptoms where there will be hypertension, activation of the red. So this is a compensatory mechanism. Because the body is losing protein, the juxtaglomerular cells secrete renin. These cells secrete renin, which activates angiotensinogen to angiotensin 1. Angiotensin 1 converted to angiotensin 2 in the lungs. Angiotensin 2 causes vasoconstriction and production of aldosterone. So, hence the name renin-angiotensin-aldosterone system. Is aldosterone missing here? Edema, water and sodium retention. Then onset, if it's sudden, you call that as acute glomerular nephritis. If the onset is gradual or repeated over time, then classification is the chronic glomerulonephritis. So, in acute glomerulonephritis, chances are that the baby will have fever because this is the time that the body is also trying to clear out the group B hemolytics, group A beta hemolytic streptococcus. Now, I want you to remember that this infection, the microorganism, remains confined to the respiratory system. We're not talking about microorganism entering blood, but what enters the blood are the antigens which later combine with the antibodies produced by our own cells. When those combine, they form what you call immune complex. Now, in other infections and so on and so forth, the complex, when antigens are bound by the antibodies, that complex is soluble. All right? Anything soluble is easily removed from the body by the kidney. If a compound is insoluble, the kidney finds it very difficult to eliminate that. And that's how they cause damage to the glomerular basement membrane. If you're doing your history, you find that this baby will have some tonsillitis. So they had some prior tonsillitis or upper respiratory tract infection in a month or so. Proteinuria, of course, due to damage to the basement membrane. Headache would be severe to mild due to accumulation of toxins. Oliguria, diminished glomerular filtration rate, and the periorbital edema. You saw that baby from the start with puffy eyes. That is called periorbital edema. Blood pressure will be slightly elevated. The patient will have inguinal pain, dyspnea due to pulmonary congestion, weakness, fatigue, quite so many signs and investigations. Of course, we always start with history and physical exam. What is so cardinal under history? So you have to see if the baby had some urinary tract, upper respiratory tract infections, tonsillitis, rheumatic heart fever, or disease, or indeed some skin disorders caused by group A streptococcus, such as impetigo. Then you have physical examination. You are looking at the baby in your presence. What can you see? What do you expect to see? So the baby can have an asaka, known as generalized edema, or in the early stages, edema confined to small areas of the body. You have a puffy face called periorbital edema around the eyes. So you see the lower lid swollen and the upper lid swollen. The eye is almost completely shut off. During urinalysis, I think they should have been separated. Let me do that. Yeah, just a minute. So this goes under urinalysis. So urinalysis. What will urinalysis show us? There will be hematuria, proteinuria, and others. So proteinuria. TC. Yeah. Those are investigations and the antibody assay. So may show presence of immune complexes. This is a investigatory tool that is used to isolate certain antibodies in blood. So you find the immune complexes associated with the group A beta hemolytic streptococcus. Then a throat swab will be necessary, especially if there's history of upper respiratory tract infection, and most of the times they'll come positive with group A beta hemolytic streptococcus. I think this is already mentioned. Proteinuria, foam urine, hematuria, blood that will appear pinkish red, that is hematuria, to be forming because of proteinuria and electrolytes that are being lost. Glomerular filtration rate will be reduced since the patient will have oliguria. Blood analysis will show higher levels of creatinine, urea, and other nitrogenous-based waste in blood, which may cause azotemia. Erythrocyte sedimentation rate becomes elevated because of the toxins in blood. Treatment, how do you treat? So the treatment focus goes to ability to clear out the organism itself is still there. So we treat that with antibiotic. Then neutralization of the immune reaction. Remember, the antibodies are produced by the body, and they're the ones that are binding to the insoluble antigens, forming an insoluble immune complex. So, want to reduce the activity of the body towards this microorganism. So you have to give the patient some anti-inflammatory drugs, corticosteroids, and so on. So the first line, of course, we're going to give penicillin or erythromycin for 10 days. You are trying to eradicate streptococcal infection. So benzathine, penicillin, depending on the weight, you can give 600 international unit, or in more, or adults, you can give 1.2 mega units. Mode of action is a bactericidal, therefore destroys the microorganism completely. Erythromycin, being a bacteriostatic, may need another or may act as an adjunct to facilitate entrance of another antibiotic so that there's total eradication, entrance into the cell, because penicillin will cause perforation in the cell wall and then the cell is damaged. So to cause that quick action, you may need a bacteriostatic agent. What about the increase the fluid that we are having? So antihypertensive drugs will be available and useful. In this case, can give furosemide or an angiotensin converting enzyme inhibitor to block the RAS system. In this case, enalapril. A corticosteroid to reduce the immune response so that we don't form more immune complex that will cause further damage to the glomerular basement membrane. Diet modification. We want to reduce the amount of protein so that we don't form as many antibodies as possible. Reduce sodium intake so that edema can subside. Then, of course, monitor fluid intake and output to prevent overload. Otherwise, that will put so much strain on the heart, and that can complicate into heart failure. Then promote rest and avoid strenuous activity. So these are treatment modalities. Antibiotic therapy, number one. Antihypertensive, corticosteroid, dietary modification, and the rest. Yeah, those are the areas of management. So same applies to chronic glomerulonephritis. What is the aim when you're managing such kind of a baby? Most importantly, you want to eradicate causative agent. That is if there's active infection taking place. Remember saying usually it's about 2 to 3 weeks after infection with group A beta hemolytic. Okay, there could be some residual microorganisms we want to clear out with penicillins or other types of microorganisms or antibiotics. So manage underlying condition in an event that this is caused, for example, by syphilis, treponema infection, or maybe it's caused by some metabolic disorder like diabetes or cardiovascular disorders like hypertension. Manage that, then spare the kidneys. Next, the baby is swelling, they're having edema, so you should control that as well. Then make sure that you preserve renal function as much as possible so that it doesn't complicate in renal failure. Prevent complications, most importantly, renal failure and the potential infection from the ward of admission. Monitor intake and output, especially sodium and water intake and output. Then, of course, psychological support or care is always important for our clients. So most importantly, this baby is ambulant, the baby is otherwise okay. Make sure that most of our care is focused on the child being able to have enough rest. So that environment that you have nursed the baby in, make sure it is promoting rest. It's clean, it's free from infection, free from, repeated, people moving up and down. So restriction must be there, noise free, free from infection. Position, they are still ambulant. They can take up any position that they want as long as it doesn't affect their breathing. Observations. Vital signs are important. Daily weighing is important also to see if the edema is responding to medication. Then input and output. As usual, because of the edema that they have, there's a chance of pressure sore formation. Therefore, observe pressure areas and do pressure area care. In analysis, observe the amount of urine that is output. You see the consistency, if it's changing or actually worsening. Psychological support. Nutrition, most importantly, you are restricting protein and sodium intake as well as fluid to prevent overload and the exacerbation of the edema the child already has. Exercise, the baby is almost, most of these patients are fatigued, and you can help with some passive exercises while in admission. If they're able to move up and down, at least encourage ambulation. That promotes venous return and prevention of other complications like bed sores, deep vein thrombosis, and others. Medication, I think we spent time on that one. I can skip. Patient education. Yeah. So here we want to make sure if it's a child, patient education should go to the primary caregiver, the parents, emphasizing on drug adherence, modification of diet, and lifestyle. So fluid intake should be restricted. Salt intake or sodium should also be in smaller proportions. Complications, mostly if poorly managed, babies may develop renal failure. Because of raised blood, nitrogenous waste, such as urea, creatinine, and others, patient can have convulsions, then excessive accumulation of fluids in the tissue causing an asphyxia and ascites. Heart failure, when the kidney is affected, the heart most likely will be affected as well. Then you have, hypertension. So basically, in summary, what is glomerulonephritis? This is a renal disorder in which there is damage to the basement membrane in the glomerulus, giving us the following: proteinuria, hematuria, and diminished glomerular filtration rate, periorbital edema. Those are the few signs I can mention. Then next, looking at the causes. What are these causes? They have categories. We have infection, autoimmune disorders, metabolic disorders, and others. Pick from that. Signs and symptoms, they are quite so many in range, from disturbances or abnormal urine, excessive accumulation of fluids in the tissues, and loss of protein in plasma, called proteinuria. Yeah. Classification, we're saying, is based on three foundations. Number one, we're looking at the duration. Is progression of this disease rapid? Then that is acute. Is it slower over a longer period of time? That is chronic. If you look at the kidney under a microscope, especially the glomerulus, is there any indication of proliferation of new cells in the glomerulus, the mesangial cells? Then that is diffuse proliferative glomerulonephritis. Then you have membranous, presence of protein-rich deposits on the basement membrane. Then finally, looking at the origin of the problem. Is it within the kidney or outside? Within the kidney, primary. Outside the kidney, secondary. Then management is in those treatment modalities. Antibiotic therapy to eradicate infection. We are looking at immunosuppression. You don't want the body to continue producing antibodies, so you push in corticosteroids. Next is management of edema itself. So use antihypertensives. Then we modify diet. Reduce protein, reduce sodium, reduce fluid, or monitor strict intake and output of those areas. Then finally, promote rest so that the body can recover and cause a repair of the damaged basement membrane. That being said, I'm leaving you with this question. Draw a nephron, explain the pathophysiology, state symptoms that this baby will present with, then management. How do you manage this baby? Then finally, how do you care for this baby if they are brought to you this disorder? This is where we end the discussion on GN.